Colleagues, so afternoon to you again. Today's presentation will be divided into 4 sections. Firstly, I'm going to be taking you through a brief overview of some of the more prevalent mosquito-borne diseases in the Caribbean region and the integrated strategies that we use for their control. Next, Mr. Rajesh Raghu, our Senior Technical Officer, Vector-Borne Diseases, will be walking you through a brief review of some guidance developed to aid our vector control operators to conduct their work safely during the COVID-19 pandemic. Then, Dr. Cheryl Jones, Behavioral Scientist at CARPHA, will deliver some considerations for COVID-19 and vector-borne disease prevention, looking at how to encourage and engage our communities to increase participation in prevention activities. And finally, we will have Mr. Jermaine Lake and Ms. Julianne Mannix from the Ministries of Health, St. Kitts and Nevis, and Antigua and Barbuda, respectively. And they'll be sharing some of their perspectives on national vector-borne disease management during the COVID-19 pandemic. Okay, so let's get into an overview of mosquito-borne diseases in the Caribbean and some of the key issues that would have occurred in 2020 and now have spilled over a bit into 2021. Okay, so vector-borne diseases are caused by the transmission of viruses, bacteria, parasites, etc., through arthropods and rodents. And they account for about 17% of the infectious disease burden globally. The WHO projects we're looking at 700 deaths annually. And generally, the risk is highest in the tropics and subtropics. In the Americas and the Caribbean region, we have a very high focus on mosquito-borne diseases, such as dengue, chikungunya, and Zika. And I think we're very well aware of and remember the chikungunya and Zika outbreaks that occurred in 2014 and 2016, respectively. And also, some of our countries are engaged in elimination efforts with respect to malaria. And then yellow fever is still a concern in a few of our member states. With respect to COVID-19 over 2020 and 2021, we have experienced a situation where we've had circulation both of the pandemic virus as well as arboviruses. And we have seen the strain that this has placed on our regional health systems. So mosquito-borne diseases are not our only challenge. The COVID-19 pandemic has affected us globally and necessitated changes in how we approach both our personal activities and work. As of this week, March 22nd, 2021, we're seeing more than 120 million cases worldwide, with approximately 2.7 deaths. In the 26 CARPHA member states that we serve to date, over 129,000 reported cases of COVID-19 have occurred, and the highest daily number was seen in early December in the small island state of Bonaire, and currently Jamaica is reporting the highest incident rate. Let's take a look at some of the epidemiological data. Focusing in on syndromic surveillance, specifically undifferentiated fever in the less than 5-year and greater than 5-year-old groups, most cases under this syndrome are largely attributable to arboviral diseases. For example, dengue, and then lepto is also quite a bit of a feature there. To a lesser extent, we see cases of malaria, brucellosis, typhoid, and paratyphoid. In terms of the syndromic data reported to CARPHA last year in 2020, over approximately 25,000 cases were seen by Q4 of that year, with the greatest quarterly increase observed in that last quarter. For the first quarter of 2021, we're not seeing as much activity when we look back at the same period in 2021. In the first quarter of 2021, we're not seeing as much activity as we did in the first quarter of 2020. And that's good news. Focusing in on an example of dengue, our CARPHA member states report both in-country lab-confirmed data as well as clinically suspected cases. So again, for that last year, we were seeing an increase in the number of cases that were submitted for testing to our CARPHA medical microbiology lab. Based on that testing, we saw about, well over 1,000 samples received, and dengue serotypes 1, 2, and 3 were circulating. While we test for dengue, we also simultaneously test for chikungunya and Zika, but we detected no positives, which suggest that transmission is either very low or occurring not at all. By August, September of 2020, we had some of our member states reporting a few localized dengue outbreaks, and dengue 3 was the primary serotype circulating at that point in time. Right, with respect to first quarter 2021, we've seen about just dengue 1 detected so far in terms of what we received for testing. Just to quickly review some key facts on major arboviral diseases in circulation in the region. A quick highlight on dengue. Dengue virus is in the flavivirus family, and it's transmitted primarily in the region by Aedes aegypti and to a lesser extent by Aedes albopictus. With respect to Zika, I'm sure we all remember that epidemic in 2016. The vector is the same, Aedes aegypti, and it was, of course, greatest concern to pregnant mothers and the possible risk of microcephaly and other complications in newborns. The next one that we saw within the region in the past decade was Chikungunya virus. And usually it's not painful, or sorry, it was very painful, but it's not fatal. And chikungunya itself, it's an African word, and it means that which bends up. The primary symptoms were fever, joint pain, headache, muscle pain, joint swelling, and rash. Thankfully, however, we haven't seen chikungunya much, except for a few imported or sporadic cases, all right? But we did know that in 2019, there was a resurgence in Latin America. So it's still something that we have to be very mindful of as more time passes and we have an increase in our susceptible populations who may not previously have been exposed to chikungunya. Now, in terms of mosquito-borne disease management strategies, well, I'm sure many of our environmental health and vector control officers online, they would have heard of the term integrated vector management. And if we focus in on mosquito-borne diseases, we're looking at integrated mosquito management. And this is effectively a program that utilizes a various combination of techniques to control mosquitoes at all life stages. Some of the areas that we look at include mosquito biology and reproductive behavior, because we would like to be able to identify species accurately. Then we have entomological surveillance and monitoring. Here we want to look at the size and distribution of our mosquito populations. Next, we would like to look at setting action thresholds for prevention and control activities, and that is usually carried out based on your entomological indices. We can also use GIS data to visualize the spread and density of populations and the location of disease cases, thereby aiding risk and vulnerability assessments. In terms of control techniques, we usually employ physical, biological, as well as chemical control methods. And with respect to chemical control, we always need to be very mindful that insecticide resistance testing should be carried out to ensure that you are using the most effective chemical on your mosquito population. But it's also very important to practice environmental stewardship in order to reduce the risks associated with the usage of pesticides. Focusing on a strengthened multi-sectoral approach involves looking not only at public health, but we need to reach out to our agricultural sectors, education, tourism, legal, finance, planning and development as well. So all of these approaches combined really help us to ramp up our prevention and control activities. In terms of entomological surveillance and expanding on a few of the areas that we just mentioned, entomological surveillance looks both at larval and mosquito populations. Key to this is the identification of mosquito breeding sites, estimating population numbers, and here your entomological indices such as your Breto, house, container index, etc. come into play. Another key area in surveillance and determining risk is trying to assess whether the virus is also presently circulating within your population. Presently, CARPHA has a mosquito-based arboviral surveillance program, where we test adult mosquitoes collected through our member states for a panel of viruses. So we'll basically test for the usual ones, dengue, chikungunya, and Zika, but we will also survey yellow fever, Miara virus, West Nile virus, and then a few non-endemic African viruses, for example, Spondwani virus. Now, why do we want to expand our range of testing? We're really trying to determine at what point some of these new viruses actually become introduced into our region. And we do that because the precedence was set by Zika and chikungunya. In terms of physical control techniques, of course, we're going to be looking at source reduction, eliminating the sites where mosquitoes develop. Then we have biological control. Here we can use natural predators to reduce the number of mosquitoes, for example, guppies, and tilapia. And then there are some new technologies for consideration. I'm sure many of you are aware of sterile insect technology and the use of Wolbachia to try and control mosquito populations as well as reduce disease transmission. There have been a few experiments or pilot studies within the Caribbean on some of these technologies, specifically the sterile insect technologies. However, it's not widely implemented for a variety of reasons. One largely reason is due to the sustainability of technology within the region. Many of these techniques are very, very expensive to roll out and also carry out on a periodic basis. And then lastly, of course, we have chemical control, where we use insecticides to control our mosquito populations. Now, in terms of disease surveillance in our CARPHA member states, typically our countries report clinical or suspect disease cases from Sentinel sites, and these sites are usually local health centers, hospitals at the district or parish level, and sometimes the national level. Depending on what our countries are seeing and if capacity is required for laboratory testing, specimens will be collected and sent to the CARPHA Medical Microbiology Laboratory. What's very important for a country that's experiencing an initial dengue outbreak, it's essential to determine in what specific locales within the country that we actually have dengue transmission taking place. But once we've established that transmission is taking place within a specific district or parish, it's not necessary to confirm every case because, of course, testing and especially PCR testing can be quite expensive. So we need to conserve our resources. From an epidemiological standpoint, of course, just testing a few or a select range specified by our epidemiology staff will help with the information that we need. In terms of laboratory testing, most countries of our member states do have the capacity to carry out lab testing confirmation through ELISA testing or serology, and that's usually based on antibody and antigen testing. And quite a few of our countries now do also have PCR capacity where they can obtain dengue serotype information. I do need to point out that lab confirmation really comes through the use of the ELISA and PCR techniques. Testing via rapid tests, that's primarily carried out at Sentinel sites, for example, our health centers, but it's really more of a screening tool and not a confirmational tool. And that's because our rapid tests really aren't very sensitive or specific. Much greater accuracy is obtained through the use of ELISA and PCR. Now, this slide is very busy, but I just wanted to very briefly mention that it shows a climate publication that's produced by various regional entities. Now, mosquito-borne diseases are climate sensitive, meaning that the biology, behavior, and breeding patterns of the mosquito vectors are affected by climatic variables. When considering your vector control operations and planning for the year, the climate outlook will be a major factor for operations management. So here we have a quick little snapshot of the temperature and rainfall patterns for the region projected over the next few months. And this data is very important, again, in terms of factoring your planning for your vector operations. Now, the Caribbean Institute for Meteorology and Hydrology, in partnership with CARPHA and PAHO, produce a quarterly health climatic bulletin. It's a very informative publication, and it highlights the upcoming weather patterns for the next quarter. And it also addresses the public health priority diseases that will be affected by these weather changes. Now, recent research in the region has demonstrated that drought conditions that are followed a few months later by higher than usual temperatures and then excessive rainfall greatly increases the chance of dengue outbreaks. In 2020, the region did experience an extensive drought period followed by intense heat and then excessive rainfall during the wet season, particularly in the Eastern Caribbean. Concurrently, in the last quarter of 2020, we noted a resurgence of dengue, with several islands in the Eastern Caribbean experiencing localized dengue outbreaks. We have just reviewed that weather and climate changes are critical factors that must be considered in vector control operations. But let's just take a quick look at exactly how they can be used. One of the most effective strategies in surveillance is to use an integrated approach, where we combine different streams of surveillance data to provide evidence-based information for public health decision-making and prevention and control measures. Within our member states, this is practiced to some extent, but a fully integrated approach where we combine entomological, disease, and environmental or climate data is a journey that we're really now embarking on. The various data sets that I mentioned can be used in spatio-temporal models to produce risk maps for varying time periods that can aid in planning of both short-term and long-term prevention and control measures. These models contribute to early warning, which effectively will prompt early planning and action. In terms of CARPHA's regional vector-borne disease prevention activities, presently we have a very large grant from the European Union that is funding the majority of our interventions in our member states, and that will take place up until 2023. Right? This is the banner that we're presently using at the moment, and we have our background in today's session. Sorry, so just to give you a quick highlight of that particular project, the overall objective is to improve the health of the Caribbean people through a reduction in the morbidity and mortality associated with Zika and the mosquito-borne diseases. The project has 5 major result areas. And firstly, we're looking at increasing the capacity for detection, monitoring, and surveillance of Zika and other mosquito-borne diseases in the Caribbean. Result 2 is focused on strengthening vector control operations. Result 3 looks at increasing public health education and behavior change programs on mosquito-borne diseases. Result 4 looks into the research that has been conducted in the region and trying to gather and assimilate that research so that it can aid us in public health policy and planning. And then finally, result 5 looks at strengthening our regional partnerships, regional and international partnerships in order to prevent and control of vector-borne diseases within the region. So we're looking at working with our member states, partners such as the EU, CDC, PAHO, etc., and of course our regional universities. With the emphasis on COVID-19, disease surveillance for dengue and other arboviruses was significantly affected in 2020. Human and financial resources were dedicated to the pandemic, and the effect of that was the slowing of the response time to mosquito-borne disease outbreak situations. We also had a reduction in the specimens that were submitted to the CARPHA Medical Microbiology Laboratory during the first half of 2020 when compared with previous years. Submission in the second half of 2020 did increase, however, when we started seeing some of those localized outbreaks. In 2021, the key message will be that we need to maintain surveillance for dengue and other mosquito-borne diseases to prevent the additional burden that is placed on our health systems, which are already strained by COVID-19. Right, so that is it from me. I'm going to close off and hand back to Ms. Garcia.
Thank you so much for that informative presentation, Dr. Boudram. And now I'd like to open the floor for the questions in our Q&A forum. Please lodge your questions in the Q&A tab. Okay, Dr. Budram, question for you from Sharian Bechan. It reads, was there adequate response by CARPHA and its member states during the Zika outbreak to prevent and control the spread of the disease? What were the gaps, if any, in the detection, prevention, and control measures? Over to you, Dr. Budram.
Okay, thank you very much, Sharis. So definitely, I will have to say that there was a very, very strong regional response, both by CARPHA and our member states to the Zika outbreak. From the time that the World Health Organization declared Zika as a public health emergency of international concern, that allowed the globe to basically marshal resources and send aid to the Caribbean region. CARPHA received quite a significant bit of funding through the European Union and the CDC. And together, in conjunction with other partners such as PAHO, we were able to reach out to our countries and provide laboratory diagnostic and testing support. We worked with other partners in terms of general surveillance. We also worked in terms of vector control operations and strengthening. So here we're looking at integrated vector management in general, both some GIS and insecticide resistance testing applications. And then additionally, we focused in heavily on the community engagement aspects. So there was direct health promotion and community outreach in all our member states. And CARPHA additionally undertook some knowledge, attitude, and practices studies so we could actually formulate some of those key messages that needed to get out to our populations. So very much CARPHA in conjunction with our regional and international partners and our member states, there was indeed a quite significant and adequate response at the time. Of course, it would have taken a bit of time for the epidemic itself to come under control, but I can safely say that the majority of cases were seen in 2016, and by early 2017, we were seeing very, very few cases, and by 2018, Zika had basically disappeared from the epidemiological profile within the region. Of course, quite a bit of that would have been attributable to herd immunity, but yes, the response by the region was quite significant indeed. Okay, I'm seeing another question. Was there any significant rise in microcephaly and or Guillain-Barré syndrome in any CARPHA member states after the arrival of Zika? So I will say in terms of Guillain-Barré, we had a very few cases reported by our member states, just one or two here and there. In terms of microcephaly, thankfully, I will have to say that although there were a few cases in our member states, the numbers reported were very low. I think the maximum would have been less than 20 in some of our smaller islands, thereabouts. So while we did see some cases, no, there was not a highly significant rise. And I would definitely like to think that this was attributable to some of the prevention and control methods that we would have employed within the region. In terms of the next question, was there any follow-up of the Sikuli of chikungunya in the wake of its outbreak in the Caribbean? I will have to say that a few studies were conducted in CARPHA member states that did look at this. However, they weren't very long-term studies at the time. And I do have to say there should be a little bit more work done on the chikungunya. So some work was done, but perhaps not enough follow-up. Definitely, we don't want another epidemic occurring, but it's still an avenue that probably needs to be explored. Because we do know that, especially in the severe cases of chikungunya, persons can be affected for many, many years, including even beyond, a decade past the initial infection period, right? Okay. Right. I'm also now seeing a few questions. Okay, one question in the chat, and that is from Dr. Dacey. Hi, Satish. Good afternoon. Okay, so your question is, does social and physical distancing together with restrictions increase domestic or home-based risk for exposure to mosquitoes and viral transmission? So that's a very good question, Satish. It has actually been asked. What I can say though, based on the reports from our member states, at least in terms of the actual evidence or data collected, we did not really see that per se. The localized dengue outbreaks that we did see towards the end of 2020, that last quarter, as I explained, it really was due to the weather conditions that were ideal for promoting the increased breeding of the vector towards the latter half of the year. So yeah, no real evidence to speak to that question that you did ask.
Just to interject a gentle reminder, any questions that are non-technical, please place them in the regular chat box, and any technical questions as it relates to the webinar to be placed in the Q&A forum, please. Thank you.
Okay, so thank you very much, Sharon. So I'm going to hand you back to introduce the next speaker.
Okay, thank you, Dr. Boudram. And now I'd like to introduce our second presenter, Mr. Rajesh Raghu. Mr. Raghu is a spatial epidemiologist with training in geographic information systems, integrated vector management, medical entomology, and parasitology. He is currently employed as the Senior Technical Officer for Vector-Borne Diseases with the Vector-Borne Diseases Unit at the Caribbean Public Health Agency. His basic duties and responsibilities with CARPHA include providing expert technical support and advice to CARPHA, CARPHA member states, and relevant stakeholders. Secondly, coordinating the development of a CARPHA-specific strategy in the area of vector-borne and parasitic diseases. Third, collaborating with the CMS's key stakeholders, the Communicable Diseases and Emergency Response Department of CARPHA, and relevant others in the planning and implementation of vector-borne and parasitic-borne disease outbreaks response measures. For participating in vector control field operations to achieve high quality standards of intervention. I would now like to invite Mr. Raghu to take the floor. Over to you, Raj.
Thank you very much, Charis, and good afternoon to all the participants in the COVID-19 and mosquito-borne disease webinar. My name is Rajesh Raghu, better known as Raj. Most people know me as Raj. And I'm here today to chat with you all about the vector control operations during the COVID-19. Yeah. So if I could turn the cameras around, I would show you all that the first part here, we have step one, which is a weather assessment. I would show you the weather in Port of Spain today. It's very, very rainy, and we're theoretically, I think, in the dry season. But we've been having a lot of rain, and Dr. Boudram did a very good job of explaining the association between the climate and weather and mosquito-borne diseases and the proliferation of Aedes aegypti given particular weather patterns. And so the first step in our 5-step guidelines here for vector control operations is looking at the weather assessment. So we have the suggestion that we should be using meteorological information broadcasts, and this type of information really should guide the types of vector control responses over the COVID-19 pandemic as it progresses. And it's not really specific to COVID-19. These are good advice for general vector control operations, and for several reasons. So we want to say that we should be paying attention to the short term, which is we get weather forecasts in different formats. Yeah, there's a short term format where you can get it in weekly, which you normally see over your radio, television, and all of that. And you can get a longer term or 3-month type weather forecast, right? And this will allow for planning ahead, and specifically with entomological investigations. We've seen what happens when you come out of a drought period, as in 2020. We've come out of a significant drought period into significant rainfall, so which means that you're having very high temperatures and a lot of rainfall, which is a nice combination for increasing the proliferation of Aedes aegypti. They like patterns like that because they can reproduce very, very quickly, and the developmental cycle is much faster. So we're suggesting that you utilize the weather assessments to enhance your entomological surveillance. And on the ground entomological surveillance, we're saying should be timed such that it would intersperse the wet periods. It's not really too practical for Vector to be doing vector control inspections, house-to-house inspections, and all that during the rainy periods. It's more difficult to do things like adulticiding and larviciding control measures when there's a lot of rain. So what we want to do is to try to time it so we can get those dry spells, those dry periods where we can carry out entomological surveillance and treatment. And the suggestion here is to utilize some Sentinel sites. And one of the reasons for that is to minimize the house-to-house surveillance that it's traditionally done. So if we set up a Sentinel site, we can utilize entomological surveillance techniques like trapping, adult trapping, or we can shift to something like a modified house-to-house survey using stratified random sampling instead of the traditional house-to-house inspection, right? Along with that, things like hotspot analysis and collecting the entomological data and doing that hotspot analysis based on the clusters of not only the epidemiological data that you find, but the epidemiological data as well. Putting those things together can give you a good idea of where the vector control operations should be focused. So here we push into what's targeted vector control interventions rather than the traditional cycle system. And we're saying this in response to the COVID-19 protocols that are in place. We want to minimize the amount of contact that the vector control operators have with homeowners and community persons in the community. So by using the stratified random sampling, using the Sentinel sites, we can sort of prevent the usual contact that persons would have with members in the community. The other thing is to look at step 2, which is a field risk assessment. So this follows from the first point. And in doing a risk assessment, we need to look at the persons who are involved, the vector control workers who are out in the field doing the house inspections, premise inspections, trap maintenance and servicing. We need to look and procure the relevant PPE, right? Such things like water and masks and gloves and alcohol, etc. Some of which Vector already uses on the field, but it may need to be enhanced in certain places. So it's a revision then of the protocols for community engagement with physical distancing concepts in mind. So even if you're going out to the houses to do house inspections, you know, the protocols with meeting and greeting and interacting with the homeowners needs to change given the COVID-19 protocols. Premise inspections we're suggesting then should be strictly limited to the external environment like yards, yard spaces, and not have vector control workers go into premises to do inspections. Equally important then is the fieldwork risk assessment sensitization sessions. If we're changing the protocols that we use in the field, it's very important that the vector control workers are sensitized to these new protocols. If we're doing stratified random sampling, if we are not interacting with the homeowners in the traditional sense, it needs to be adapted, and then the homeowners, sorry, the vector control workers need to be sensitized as to what are the new field protocols, so everyone is clear. Right? We suggest in here this should be based on the country's culture and nuances, because every country you go to is different. Yeah, the culture is different, and the way that you would carry out some of these operations would be different. Then there's the issue of getting out into the field, which is step 3 that we have here. So transportation and field logistics. We know that there are different types of vehicles that take workers out into the field. Sometimes there are these pickup type trucks that you see on the photo at the top. This is a photo pickup with an open tray, right? Below, the second photo shows a minivan type of setup with more seats, sometimes up to 12 seats or so, right? And then, so carrying workers out on the field, there's not only the risk of worker to person, community person, personnel contact, but you also have worker to worker contact. So the seating density on the vehicles is one of the things that we need to pay attention to. I think the general rule is to do 1 person per window sort of setup where feasible. And it might therefore be necessary to make several trips out to the field. So planning this sort of field work takes a lot more out of the vector control team in terms of the planning sessions before you actually get out into the field, given that you now have to deal with entomological surveillance in a different way, and now field logistics in a different way. In the field, it's recommended that those carrying out the inspections try to work singly rather than in pairs. And again, it's to reduce contact among the workers themselves. And once the safety assessment allows for it. So we know in certain places, you know, vector control workers work in teams because of safety. So that safety assessment is also required. The advantage with having vehicles is that, you know, the vehicles, you can stock personal protective equipment and things like extra water for washing hands and soaps and sanitizers and alcohol and all of that on board the vehicle, so that the vehicle stays with the vector control workers and they're able to supply the workers with the necessary water for washing hands and soaps, sanitizers, and things that they need to keep safe. The 4th step is looking at the adult mosquito population infestation. And we know that in certain circumstances, there's no getting around doing adult vector control, chemical control specifically, because when the numbers of adult mosquitoes get too high in a particular area, when the density gets too high, it poses a significant risk for arboviral transmission, and a quick knockdown is therefore needed. So during what we're saying though, that during the COVID-19 pandemic specifically, because COVID-19 is a respiratory type disease, this sort of operation should be minimized as far as possible. It means then that we need to utilize the entomological surveillance techniques to be able to determine what are the areas of high mosquito densities, and then use that to do targeted vector control interventions. The other issue is the choice of equipment. So do you go there with a thermal fogger, or do you go there with a ULV machine? both of which generate different types of adulticide applications. So a thermal fogger would give you more of a high density fog, which is what you see most people refer to as a smoke, right? And then the ULV machine gives you more of a mist, and there are advantages and disadvantages with both of the systems, right? Step 5 is looking at public education campaigns, and the key message here is to remind the public of the association between the weather and the risk of arboviral transmission, and continue with the public awareness and public education campaigns. We're saying here to use the mass communication channels to be able to do this. And here to give you a little bit more on the public education, the community engagement would be Dr. Jones in a few minutes. But as part of our guidelines here, we are recommending that we utilize the community engagement strategies, which will minimize the risk by reducing contact between the inspectors and the public, right? So it's to craft those messages and utilize the messages where we can. We recognize though that it's a battle in trying to get vector control messages out in a time where COVID-19 messages are bombarding the airwaves. So the general advice and takeaway messages are to focus efforts on the known hotspot areas for arboviral disease outbreaks, emphasizing source reduction and education. So we're moving away from the traditional house-to-house type inspections, right? It might be useful to develop fun, clean source reduction exercises that capitalize on these stay-at-home interventions. A lot of persons are home. If we can somehow capture that audience that is home and engage them with some, creative puzzles or competitions or something that will engage them and yet get the message, help to get the message of mosquito-borne diseases across to them. It's critical that entomological surveillance operations continue to operate within the framework of the established country-specific IVM. Most of our member states have their own IVM program, right? So it would mean modification a little bit of the IVM program to adapt to this ongoing COVID-19 pandemic. It's also important that vector control works very closely with the labs and the epidemiology units to increase the response time for suspected and confirmed arboviral cases. So the idea here is that we want to be able to target those areas where arboviral cases pop up. And the vector control team needs to get that information very, very, very quickly, because the faster that they can get out in the field, do the entomological investigation and get the numbers of vectors, the vector density down, the better it is for reducing the risk of arboviral disease transmission. And lastly, to continue the public education campaigns and find creative ways of navigating the COVID-19 messages. So thank you very much. That was just a brief overview of our 5-step guidelines, and we'll open the floor for questions. Charis, over to you.
Thank you, Raj, for that informative and enlightening presentation. And now we'll open the floor to the Q&A forum. Please post your questions in the Q&A chat. Thank you. Okay, Raj, I'm seeing a question here that's from Cheyenne Watson Moody. Is there any research comparing UIV fogging and swing fogging to suggest which procedures have more results?
And that's a very, very good question. And unfortunately, we haven't seen many published papers on comparing ULV fogging with thermal fogging. There are a few papers too. And what the papers point to are the differences in the application methods of using a ULV fog, which is a cold fogging, right? A cool fogging system rather than the thermal fogging. And within the region, there's very little studies have done on it, which is an interesting thing, because our climate here is much different to other parts of the world. And we know for a fact that temperature and humidity affects the way that these machines deliver chemicals in the field, right? So in terms of the efficacy, we can tell you briefly that if it's a hot day, very hot day and it's very windy, a thermal fogger is not very effective. Whether it's truck mounted or handheld swing fogs, they all lose the fog very, very quickly, right? In cases that ULV machines are a little bit better. But in terms of its efficacy, there are other factors that other than climate, such as terrain, for example, some places that you may not be able to physically drive with a ULV machine, and you might be able to go in with a handheld thermal, right? So that's a complex question to answer. It's multidimensional. Right.
Seen a few more questions coming in. One from Ms. Nicole Lake. Are any of the protocols being implemented as yet?
All right, so okay, I'll answer it live. So thanks for that question, Ms. Lake. And we're working with our member states to implement these protocols. So we have ongoing training with our member states in integrated vector management and insecticide resistance testing and in geographic information systems. And in all of the member states that we're working with, we use the COVID-19 guidelines very closely in the training to highlight some of these issues, especially with the integrated vector management training. We try to roll out these initiatives, work with the countries to roll out these initiatives. So far, we've been getting good feedback. Right. There's another question here from Satish, BDC. Is there a need to strengthen legislative framework to promote, enforce vector control management at the community and individual level? And if there's a need, what legislative measures are recommended? All right, so for this particular question, there are legislative frameworks available in different countries, and it varies extensively from one country to the next. Many countries have legislative framework that speak to breach of public health regulations with mosquito breeding, especially Aedes aegypti. For example, Trinidad and Tobago has a Yellow Fever Act, and the vector control officers can cite persons who are in breach of the act. Enforcement of the act, however, is a different situation altogether. And what we've seen is that enforcement, there's difficulty in enforcement in some of these legislation for different reasons. So it varies by country, and some countries choose to have punitive measures and some countries choose to do community engagement. It depends on the country.
We still have 5 minutes left to take questions.
All right, so we have a question from Mr. Neri James here. Please comment on the concept of an early warning system for small island states. Mr. James, thanks for that question. That answer will take us all afternoon to comment on the early warning systems for small island states. Just to briefly state that early warning systems are very new. We're working, CARPHA is working with our stakeholders to develop early warning systems for small island states. We see the value of early warning systems being out there, implementing things like GIS technology and integrating climate services along with epidemiological and entomological data. I myself have an affinity to this because I am a spatial epidemiologist at heart. So early warning systems, we definitely support early warning systems, and we can have much more discussion on this. Okay, Mr. Alvaro Cruz, do you predict that there is a data gap in regards to reported cases of VBD for the past year because of the COVID-19 pandemic? How would we account for such a gap? For example, can high-risk areas still be targeted for vector control even if there hasn't been a reported case recently? Okay. So there may be some underreporting of the vector-borne disease cases if countries are focused heavily and the healthcare system is overwhelmed with the COVID-19 pandemic. We expected that there would be some underreporting. However, the vector control team, as you rightly pointed out there, can respond to areas that they deem high risk in terms of the entomological indices. So it depends on the way that you categorize risk. Some countries categorize risk by combining entomological and epidemiological surveillance. Some countries can use the epidemiological surveillance, the house container Breto indices, to say that the area may be high risk of transmission based on the vector populations. And in a case like that, they can target those areas, as you rightly said, using those sorts of indices. We have another question from Veronica Marks. How effective is the use of meteorological information system in combating the breeding of mosquitoes? So that question has many layers as well too. So meteorological information can be on different scales. It can be weather-based data, which are short-term data on rainfall and temperature, precipitation. And that sort of short-term data can be used very, very effectively because it can guide the field operations. You know when you can go out and fog and spray and conduct your house-to-house inspections and your surveys, however. So I would say entomological information where you can source it and you can source good, accurate data. It's critical for your vector control operations. On a wider scale, on a bigger scale, where you're talking about climatic data, that's a little bit more tricky to predict, and that's where you need things like early warning systems to be able to deal with data on a larger scale, on a larger spatial scale and temporal scale. Right. Fazan Razul said in Trinidad and Tobago, there's the yellow fever regulations of 1979. Yes, and that is the act that I was referring to, the Yellow Fever Act of 1979. So thanks for that contribution, Mr. Razul. Sherian, just one more question here. Sherian Beechan is, I'm not sure if this question can be answered, but what are CARPHA's views regarding the international health regulations, the IHR and its member states on building core capacities to rapidly detect and control public health threats at their sources? And two, how effective has the regional coordinating mechanism for health security been in helping small island developing states towards regional health security? So for that question, I would have to hand over to Dr. Budram to answer.
Okay, thank you very much, Rajesh. And this will be the last question, and then we're going to move on to our next presenter. Of course, the international health regulations are in place. It's sort of a legal framework that all the member states, the CARPHA member stateship, as well as other countries globally have signed on to. And as Ms. Beechan clearly said, yes, it's focused on building core capacities to rapidly detect and control public health threats at their sources. So CARPHA works in conjunction with our member states and other key international development partners and regional agencies to support that effort. So it's something that's very much active and ongoing, and it's a fully collaborative effort across the board. How effective has the regional coordinating mechanism for health security been in helping states working towards regional health security? Well, I would definitely have to say that we have made some great strides in the last few years, and especially in terms of the COVID-19 pandemic. the regional coordinating mechanism, which consists of both CARPHA, our member states, our international development partners, international health agencies. We have all been working very, very closely together in terms of the COVID-19 response. And it has indeed been a very strong effort. And I would say that, yes, it has been working quite well in view of the COVID pandemic. Okay, but it is a work in progress. COVID-19 pandemic has shown us where the gaps are, and we are actively working with our member states to reduce that where feasible and using the necessary resources or resources that we have available to us. All right, so I'm going to try to close off this particular session. I'm going to hand back over to Ms. Garcia to introduce our next speaker.
Thank you, Dr. Boudram. And everyone, thank you for your questions, and please feel free to continue posting your questions in the Q&A forum. They will be answered online, and if not, again, we will answer them via email. Now moving on to the next section, I would like to introduce to you all our third presenter, which is Dr. Cheryl Jones. Dr. Jones received her training in medical sociology from Howard University in Washington, D.C. She is also an educator with a plethora of experience in research focused on social behavioral aspects of public health, as well as in the curriculum development and implementation. Dr. Jones has developed curricula and designed training modules for private institutions, including the United States university system, and for multinational corporations. Her experience in higher education includes research instructor and chair of culminating experience, the Master of Public Health Program, Morehouse School of Medicine, 2006 to 2013. Adjunct professor in Health Services Administration at Strayer University between the years 2009 to 2014, and guest lectures at various colleges in the United States and the Caribbean. Currently, she serves as the behavioral scientist for the Caribbean Public Health Agency. In this role, Dr. Jones provides technical support to CARPHA member states. Her expertise assists in the development and implementation of regional and national approaches to identify, enhance, and implement evidence-based public health interventions and innovative initiatives that seek to reduce the impact of HIV/AIDS, NCDs, or better known as non-communicable diseases, vector-borne diseases, and public health emergencies throughout the Caribbean. Dr. Jones has obtained a Bachelor of Business Administration in Business Information Systems, a Master's in Business Administration with concentrations in Finance and Decision Sciences, a Master's in Public Health in International Health, and a PhD in Sociology. Her dissertation, completed at Howard University, was entitled "The Impact of Social, Political, and Economic Factors on the Midwifery Model of Care in the Eastern United States and Port Antonio, Jamaica." I would now like to invite Dr. Jones to the floor. It's all yours, Dr. Jones. Take it away.
Thank you, Charis. And good afternoon to all of our participants. So I'm going to kind of pick up where Raj mentioned me earlier. Just to give you a background, I remember my first presentation with CARPHA was at a Zika symposium, and the focus was on how we could get the best way to rid ourselves of this mosquito. We were trying to change the behaviors of the mosquito. And my first question was, so we're looking at mosquito behavior primarily, but we're not talking about human behavior, what we can do with people to change their behavior. So I'm excited that we've kind of come full circle and we're now looking at the actual engagement of communities. So my talk is going to kind of look at community engagement lessons learned from over the last few years, probably about last 10 years, and what implications it has for COVID-19 and vector-borne disease prevention. And my slides are not advancing again. Give me a second while we resolve this issue. So we're same thing. Okay, I think we're back. So we're going to talk about community participation. Community participation is a term that I hear thrown around a lot, and community participation is like an onion. It has very number of layers. So when we're looking at community participation, we're actually looking at various responses that we want to get from the communities. Do we want them to adhere to guidelines, or do we actually want them to participate? So we're going to talk about those levels of community participation, the lessons learned from vector-borne disease prevention, what are preventive behaviors, some things that impact preventive behaviors, experiences from Latin America and the Caribbean, and then risk communications and community engagement. So when we're looking at community engagement, we're actually looking at empowering communities to make a change. So community participation is a social process in which groups that have needs in a geographical area, and given that we are now living in a very virtual world, oftentimes a virtual area, and we seek to identify needs that they have communally or in common, and that we can get them to make decisions to act in ways that improve their health. So the idea is to provide information to these groups of people that allow them to make decisions, and to make decisions that support some of the actions that we would like for them to implement. Empowerment, on the other hand, refers to the ability of people to work together, to organize, to mobilize resources, and sometimes resources will be monetary resources, other times resources will be material resources, and sometimes those resources are just ideas. So we mobilize people to come together to solve problems in which they have some common interest. So we look at participation, their skills development, we look at self-esteem and critical awareness. So community engagement and empowerment is has a host of factors that come together when you're trying to resolve a problem in conjunction with groups of people, whether they're geographically located or virtually virtual communities. So let's talk about the levels of participation and what type of health education or health promotion campaigns are relevant. So you have three main levels. You have passive participation, and passive participation is where you want someone to take a program, an idea, an intervention. So the difference between an intervention and say a program or an initiative is an intervention is evidence-based. A program or initiative may be something that's new. But we want these individuals and groups of individuals to follow the guidelines promoted by the program. So that's passive participation. The community does not, or the individual does not come together or impact on the program itself. They don't have any decision-making responsibilities. So example of that is the traditional larviciding approach. Also COVID-19 prevention protocols. You will wear a mask. to be able to go into the public. So there was no decision making for the communities. It was a guideline that was provided to them. Active participation is another level. It's not fully community, not full community engagement. It's actually the community participating in the project. So if we say we're going to have everybody wear masks and you hand out masks to persons in the community and ask them to share them with people because you feel that that person will encourage people to wear masks, that's not full community engagement, but it is active participation. So full community engagement is where the empowerment comes from, and it's known as a bottom-up approach. So that with this type of community engagement, the community is involved from the beginning of the project, or from the beginning of the initiative, from the beginning of the intervention. The community is involved with the development of programs, identifying plans, identifying priorities, making decisions. The community is empowered to actually advocate for themselves. So this type of community engagement generally is the type of, is rarely seen in vector-borne disease prevention. We would have more likely had the passive and or the partial community participation. So it's very important to know as you're developing programs and as you're talking about in community engagement, what type of community engagement you need for the program that you're developing. And the factors that help you decide that is the amount of control the individuals have when it comes to practicing the behavior, the desired behavior. So if a community or a group of people, if there are no regulations that require, meaning if you don't wear a seatbelt, you will be fined, that's a regulation that requires a certain behavior. But if you're just trying to get people to physical distance or to reduce breeding sites, then you would need to have more participation from those individuals to understand the factors that are impacting their ability to conduct the behaviors you're asking for them to conduct. So let's talk about the lessons learned. I looked at a study that had been conducted, I believe it was from 2010 to about 2016. It was a literature review of 9 studies. 7 of them were in Asia, and 7 of them were in Latin America and the Caribbean, 2 were in Asia. And they were looking at community engagement in the control of Aedes aegypti mosquitoes. What was found that there was significant success when local stakeholders were engaged, when community members were involved in prevention, when visits to households were conducted, and when there were health education and health promotion programs implemented, and that partnerships with local services also significantly improved the effectiveness of these programs. One of the problems, or let me say the ideas that came out of the studies was, one of the studies was conducted in Cuba, and the study had community engagement type of activities with the prevention of the Aedes aegypti mosquito in a number of communities. And then in the other communities, they did not have they didn't use community engagement strategies. Instead, they just used the standard passive, set of rules and guidelines for communities. The communities that actually had the community engagement strategies were more effective. There had significantly lower indices in the intervention clusters. The challenges that all of these studies, I found in all of the studies, and it was identified in the study from Cuba, is that there were no indices that focused on behavior change. So although you could see that the indices, the intervention did result in lower cases or lower incidences of mosquito-borne diseases, they could not associate that with the behavior change. They knew that it was, but they could not identify what those behavior changes were. So there is an opportunity to look at that in the future. So what are the preventive behaviors? I'm gonna scroll through these really quickly. They are, when someone's experiences fear, they have a tendency to conduct preventive behaviors or act appropriately. When they're provided adequate levels of information and education. And that information means that if you're providing me information that I can digest, yes. If you're providing information that I need, yes. But if you're providing me information that I can't understand or information that is not what I need because you're not asking me what I need, then I will be less likely to practice a preventive behavior. Awareness of risk, of course. Other factors that impact preventive behaviors are demographics. As we know, we have to look at the demographics. Each of our member states, as Raj would have mentioned earlier, has different cultural nuances, different cultural needs. We have to look at those things. Within the context of one member state, you may have some communities that are, I don't know if it's more rural or coastal, or, in some of our member states we'll have communities that are more in hinterland, specifically thinking of Guyana and Suriname. So we have to think about those things when we're looking at behaviors. So we cannot develop an intervention without considering those things. Socioeconomic status, education level, literacy levels, health literacy levels, and gender is also a factor that impacts preventive behaviors. And when I say factors that impact, meaning factors that we need to consider and understand to develop initiatives. And the best way to consider those things is to actually have relationships or have conversations with persons representing these communities to get a good understanding of what is needed. And of course, we could talk all day about social media, and its both negative and positive impacts on beliefs, and our need to be active on social media to understand what's going on, and also to utilize social media as a tool or an instrument for sharing information. So when we look at, I think I've covered all these. The importance of community engagement, public health messaging. Okay, so public health messaging, of course, we all know that the objective is to ensure that information is shared with people in a way that they are informed to make decisions and to conduct themselves in a way that they prevent or reduce their risk of contracting a vector-borne disease and COVID-19. Some of the challenges around public health messaging in the context of the current pandemic, which was highlighted by the World Health Organization, is that we cannot continue, or we should not separate vector-borne disease messaging and COVID-19 messaging. We have to look at opportunities to, if not share messaging, share messages within the context of vector-borne disease and COVID-19 to develop messaging that is complementary and supportive, as well as looking at policy recommendations and updates from the perspective of vector-borne disease and COVID-19, the intersection. Risk communication and community engagement, I'm going to talk about, and this is my last topic. Risk communications and community engagement is something that is critical in addressing any outbreak and or crisis. Risk communications and community engagement has 6 areas of focus, and these are the 6 areas of focus: risk communication systems, internal and partner coordination, public communication, community engagement, managing information, and capacity building. Risk communication and community engagement occurs in different ways depending on the level of response you're in. So for instance, for COVID-19, in the preparatory phases to the response, risk communication systems would be developed, strategies would be put in place to begin to deal with the epidemic before it became a pandemic. Internal internal partners would be identified, external partners would be identified, and their roles in the upcoming perceived or expected or forecasted epidemic would be identified or proposed. Public communication would begin, identifying that there could possibly be an outbreak. Communities would be engaged. Persons who would have influences in communities will be identified. Mechanisms for managing information would be lined up, and then the needs for capacity building would be identified. We are now in the active response to a pandemic, and we've identified one area that is important, and that is that we continue, even though we're in the middle of a pandemic, that we continue to address vector-borne diseases, and we have to figure out a way to address vector-borne diseases and COVID-19 at the same time. So we then have to look at our risk communication systems to ensure that we make those adjustments. We look at our partners to say, okay, we've identified our partners, what can we do differently? Our public communication must change to encourage the combination of addressing both of these issues. Our communities must be engaged to understand what it is they need to know, to understand what they can do, and we have to decide at what level of community engagement we want to focus. Given that it's the COVID-19 pandemic and vector-borne diseases, I think both of them align themselves for more of the active community engagement as opposed to the passive levels of community engagement. So we have to look at ways that we can possibly bring active community engagement online and work forward to address the pandemic and vector-borne diseases. And in doing so, we have to look for ways to let the community help us manage information and identify ways to build capacity. I believe that is it that I have right now. So thank you very much. And Charis, back to you.
Thank you for that very informative presentation, Dr. Jones. Right now, I'd like to open the floor to any questions that you may have as it pertains to this section of the webinar. I do see 3 questions for you here, Dr. Jones. The first is from Mr. Satish Bidesi, and he asks, societies continue to transition from a collectivistic one to one that is individualistic. With this in mind, how feasible is the community-based participatory approach? Over to you.
Hi, Charis. Thank you. Thank you for that question. Interestingly enough, society is moving or has moved, and actually for some time has been somewhat individualistic in its approach. However, when we really look at communities, we must look at them differently. We indeed must look at communities from the perspective of where we live, where we work, or where we go to school. So even though in the places that I work, I may function as an individual, I am still working in collaboration with people. Unless you really work independently and without interacting with people, you still have some community that you have to deal with. So when we look at preventing, improving health conditions, we're not necessarily looking at it from the perspective of a collective that is clearly organized and that is reliant on each other and that has developed personal bonds. Oftentimes we're just looking at people in a physical location. In addition, you do have a community of people who are just very much individualistic, but with the virtual platforms that we use now, a lot of those individuals will have other individualistic friends in the virtual world. And we have to learn to take advantage of all of those virtual platforms that exist. And many virtual platforms exist that we do not have access to. So we think of Facebook, we think of Twitter, we think of what's the other one? Instagram, but there are also fireside chats. There are chats that are set up where you're only invited if you belong to a select group. So we have to have ways of getting information into those virtual communities to help them also be informed so that they can make appropriate health-related decisions.
Thank you. And I see a question here from Mr.
Okay, Charis, could you skip to the next one?
To Mr. Neary James, not a problem. In a Caribbean society where party politics has divided our islands into warring fractions, I'm assuming this is supposed to read, how can we really achieve full community involvement?
Very good question. We cannot answer that question until we go to the communities. So what our role is as public health practitioners is to take information to communities to help them to try to resolve issues. The health-related issues. We assume that party politics has divided us such that our islands cannot work together. But that does not mean that if we go into a community that we will not be successful. It's just an assumption that we make until we have the data that proves that this just cannot work. We actually have to make an effort to make it work.
Excellent. And another question for you, Dr. Jones, from Ms. Charlotta Charles. She states, I'm referring to a paper in the International Journal of Infectious Diseases, Serological Cross-Reaction and Co-Infection of Dengue and COVID-19 in Asia, Experience from Indonesia, Dengue, IMG.
Okay, Charlotte Charles, we will respond to you directly for that question. I believe that's it, Charis?
Yes, okay. So,
okay, thank you.
If that is all the questions, thank you, Dr. Jones, and thank you everyone again for your questions. And again, if you do have any more questions for Dr. Jones, please post it in the Q&A forum and we will answer them online or via email. In the interest of time, moving right into the next section, I'd like to introduce to you all a gentleman who's a representative from the Ministry of Health at St. Kitts and Nevis, Mr. Jermaine Lake, who is the Deputy Chief Environmental Health Officer in the Ministry of Health, St. Kitts and Nevis. He began his career as a Vector Control Officer in 1994 and then was appointed as an Environmental Health Officer in 1997. In 2004, Mr. Lake completed an associate's degree in environmental health and later a bachelor's in allied health management in 2009. He worked as an environmental health officer until 2014, when he was appointed Deputy Chief Environmental Health Officer with responsibility for vector control. Mr. Lake, you can have the floor now. Over to you.
Thank you, Cherise. I must say, though, that whoever invites me to participate in another CARPHA meeting has to supply me some doubles and some bus-up shot. I'm trying to share, but the previous presentation needs to come down first. It's still up. Thank you. So one of the main challenges we had initially with the outbreak of COVID and the lockdown and the resumption of work was a call to stand down from our regular work activities whilst we had assessment done of how we should proceed, not just with vector control, but the other programs in our department. How would the Ministry of Health, the leading agency in the response to COVID-19, how the Ministry of Health would proceed. And so it had that interregnum, that period of time where we basically weren't doing much because we were assessing the situation. You know, COVID-19 was new to everyone, and we didn't have anything on paper as to how we should proceed. A second thing for us was that some of our officers were initially reallocated to other areas where they would help with the reopening of certain businesses, ensuring the COVID-19 protocols were put in place, ensuring that what the government and the Ministry of Health had set about to do as a response was being implemented. And so we didn't have all of our officers at that time due to this temporary reallocation. So even for recommencing vector control activities, it was challenging. We couldn't do most of what we needed to do at the time. Third, I go to this term which I heard some years ago when the US invaded Iraq, and the then US Defense Secretary termed the fog of war, wherein he said that because the war had just begun and they had just put soldiers on the ground, things were not always clear. And so it was difficult to plan and to execute at times. And at that time, duties were muddied and unclear. We weren't sure what exactly we should do. Of course, we know what vector control entails, but we weren't certain as to how the officers should proceed, when they should proceed, with what equipment, etc. And so we had that period of time where things were not very clear at all. And I term it the fog of war. Then we lost a good bit of data. Nonetheless, it was part of the dry season, but we would have lost data for April and May. And that caused an inability to tailor work at the time for some of the possible hotspots. And so that period there, again, had us in a somewhat relaxed manner with regards to vector control, and somewhat lost as to where we recommence, how we recommence, and how do we contemplate for the new situation with the COVID-19 outbreak. Then one of the biggest things was that we lost a lot of financial resources that were dedicated previously to vector control. We found them now being reallocated to the immediate need to respond to COVID-19. And thus, that was a bit of a challenge for us, because soon after that is the rainy season, the time when we would see a boom in mosquito activity, the time when we need to do some fogging, we need to intensely go out and visit the premises, visit the mangroves and the other areas which are of main concern for us during that time. Lost our resources, again, weren't certain how to proceed, and we needed to come up with new ways of proceeding nonetheless. Longer term challenges, loss of funding and other financial resources. I anticipate that for the time being, we would lose certain avenues of funding and financial resources due to the need to implement the protocols and plans for the response to COVID-19, in addition to the fact that government has less revenue, government has less finances that they could allocate as per usual to the program, and thus that is something we have to deal with at least for the next year or two. Another challenge for us, how do we ensure the safety of the officers as they were going out and resuming duties on this new environment? Not only were the officers concerned about their safety, but householders were concerned about the officers coming to their premises and interacting with them, albeit at a distance. At a distant, persons then were really afraid that, you know, they believe that you could have spread it in a host of ways. Persons didn't or weren't ready to see any officers anywhere on their premises at all. And so that made them skeptical of having persons come to resume inspections and other duties. And then the officers themselves, they weren't certain, should they wear rubber gloves in addition to the masks? How far away should they stay from the persons? Should they try not to touch anything on the premises, thinking that they may be infected with COVID? Those were some of the challenges. And again, it was foggy. Information on COVID-19 was coming in rapidly and being updated. And so it was another challenge. How do we assure them of their safety? That was another issue. We could talk, we could give them all the data and the bulletins from WHO and CARPHA and PAHO, but still we weren't able to guarantee them their safety because we just didn't know. And they were constantly questioning whether they should resume at that time, how they should resume, and whether their resumption meant that their safety was at risk. Then we had this challenge of responding to the regional outbreak of dengue. Guadeloupe is 75 miles from St. Kitts and Nevis. We have ships that move from St. Kitts and Nevis, cargo vessels. We interact with St. Lucia, Grenada, all the other countries. And we needed to find a way to prevent a dengue outbreak whilst mitigating against the COVID pandemic. And that again became a challenge. And it became a challenge because, again, lots of financial resources, and it led to the last bullet on the slide, which was the procurement of vector control supplies. We needed to respond to the regional outbreak. We needed to ensure that we don't have a dengue outbreak. And even when we were able to place orders for supplies, supply chains elsewhere were somewhat broken or challenged. We weren't getting supplies during that time as regular as we should have. It took us a very long time to be able to replenish our fogging chemical control 4. We couldn't get some of the other supplies that we needed. And again, the CMO, for instance, at that time almost was pulling out of here because she said, Mr. Lake, I don't need 2 outbreaks here, which includes the dengue outbreak. And so procurement of items for vector control was very, very difficult. I recall my colleague in St. Vincent, Shamanti, I don't know if Shamanti is here, but I recall Shamanti calling me one day and asking if we have machines we could loan them, because everyone was challenged, in particular my friends in the Windward Islands, including Charlotta, who I see is here. And that was a major item for me when we got to the heart of the rainy season and mosquitoes were flourishing as usual around that time. We could not execute to the normal fullest extent. And those for us are some of the challenges that we faced during the COVID outbreak last year. It has eased somewhat. It certainly isn't where it should be or where it normally is, but I think all of us are in a similar situation, and CARPHA, with CARPHA's help and PAHO, we've been able to mitigate some of that. That is the presentation for me. If you have any questions, I'll take them.
Thank you, Mr. Lake. In the interest of time, because we have run over, we take your questions after we have the next presenter. So thank you so much, Mr. Lake, for your presentation. Moving right along, I'd like to introduce our final presenter for today's webinar. Her name is Ms. Julian Mannix, and Ms. Mannix is a senior public health inspector at the Central Board of Health for the past 11 years. Ms. Mannix has a bachelor's degree in environmental health from the College of Science and Technology of Applied Arts of Trinidad and Tobago, also known as COSTAT, and she has been responsible for the vector control unit for the past 3 years and 3 months. She is a representative from the Ministry of Health in Antigua and Barbuda. Ms. Mannix, over to you. Take over.
Okay. Hi, everyone. So I'm going to start by just giving a little background about our operations at the vector control unit. Okay. So we have taken the understanding of it. So we have your ADs team. So now this is a team that will go around and do the house inspection. So we have 32 staff that is presently doing that. We have our drain team. So we have 10 staff in that unit. So there's like tree transport that will go out and follow the ADs team, and we'll make any assessment of any drains that will need treatment. We have our fogging team. This team of 6 only work in the evening. They work on a regular basis, coming on the evening. But to assist when we're actually doing fogging, because when we have high winds, they'll be doing AD's work. But when it is possible to do so, we have some team persons that will come from the AD's team to join them. So let's say about 4 of them to make a full set so they can go out and do their fogging operations. We have a port team. So we have 2 staff in the port team that will visit all ports or airport and seaports. And we have our rodent team. So you have 5 persons on our rodent team. The persons will man our store, so they can deal with the distribution of chemicals to the staff on a daily basis. We have 2 staff there. We have 1 administrative staff who I will pass on the information to make sure that everything is running smoothly in the department. And then we have 2 staff that will deal with data entry. So when they bring in the information from the field, the staff are responsible for entering information in the system. So they pass on to me so I can, analyze information, to make decisions. And so this is a complement of 64 staff that we have in our vector control unit. And then we only have is 1 location, 1 base. So we're located here in St. John's, and we're responsible for the entire island. So we don't have any branches in the different areas. So it's just 1 base in St. John's, and the team is responsible for assessing and going out to the entire country. It's just a small 108 square miles. So other than dealing with mosquitoes, we focus on the other insects or pests that we have around, so from termites to roaches. And we will conduct inspection at schools, if it's government institution, government offices, sometimes based on the situation for private homes. So this information here is for information for the month of January, where we would have received 22 requests, persons calling me a situation where they have rats inside of a government office, or could be for the prison or any elderly care home. As you can see, our leading issues that we mostly have is with and rats. So we do focus on other things and make an assessment and treat So if we have cases of bed bugs, we have persons that are in our drain team that are trained to use the chemicals with a PP and go out and try to reduce these different pests. So in terms for our challenges that we have since the start of the pandemic was we didn't collect any data for the month of April and May because we went into a national lockdown. So we started to receive a large number of cases. So we went into a lockdown situation there because, you know, staff started to get, you know, worried. We increased number of cases, they didn't want to go out because, you know, COVID came about. So the mosquitoes got a little, you know, free time to party because they weren't seeing the team going around. So what we tried to do was to send out, do some PSAs. So we utilize a lot of our Facebook page on our national TV station, where we created flyers. So we were asking the public to make sure that they do the necessary checks. So wait until the staff on the vector control units to go out and treat for you. You can do it yourself. You don't want the public to lose focus, and they're just focusing on COVID-19 and forgot about the dangers posed by the Aedes aegypti mosquito. So we created some flyers, and when we sent those, we had like some WhatsApp group too. So we sent out the information, hoping that during that period, that the homeowners would treat their own breeding site on their premises. And we also had some videos that were shown on the national station. So also what we could have done during that period was make assessment of the drains, because now the staff was not getting in contact with the public. Everybody was on lockdown, so we got the drain team to come out. So during that time, we were focusing on the biological control. So the staff went fishing. So got some, you know, guppies from certain areas. We made assessment where it didn't have, and we had a large larval count, and we were placing guppies through all the major drains in Antigua. And, you know, that went, you know, very well. So we had that going on during the pandemic. Then when we were allowed to return, when staff started to come back out, you know, they were very hesitant. Okay, they were still saying that they don't feel comfortable going out because we had persons that were doing self-isolation. They were isolating themselves at home. So they were fearful of getting in contact with homeowners. So we had that. So the first week or two, staff were just mostly, you know, in the yard, didn't really want to go out. And they were also concerned about PPE. If we're gonna give them, you know, a supply of masks and the transportation issue, because before it was like a full bus. So if it's a 14-seater bus, it was 14 persons going out. So what we did, we reduced the capacity in the bus. So we only had 9 persons in a 14-seater. We had to get additional transportation to carry out the others and utilize different transport, so the staff could feel comfortable going out into the field. And also, you know, they give education of the staff. So, and what we did, we created, you know, this flyer. So we had that flyer going around in the media, letting the, you know, the homeowners know what to do. So when we come out of their premises, we don't want you to maintain your distance, because we do have some homeowners that will walk around with you when you go on their premises. So just ask them to maintain a 6 feet distance from the staff, make sure that the homeowner will wear their face masks, and so they, you know, can observe what the person is doing on their premises. So we did, you know, a lot of that to, you know, try to, you know, assure the staff when they go out in the field. But for, you know, presently, we're still, you know, having, you know, situation, because every time we have an increased number of COVID positive cases, the staff get worried. They still want to go to the field. When they will make an attempt to go on a premises, and even my shelter, oh, don't go into that yard because that person have COVID. Or the homeowner shelter, I don't want you here. Because sometimes they too, as Ms. Lake was mentioning, they didn't want the staff to come onto their premises because you're looking at, you know, you're bringing COVID to me. But so let me know what you can do. If this, you know, refusing for you to enter, you still talk to them. They're down the gallery or they're looking through the window, and let them know that, okay, you don't want me there, but you need to make sure that you do your checks. because we don't want it, you just leave it, you're not concerned about it because you're focusing on COVID. And for when the staff do go on the premises, we'll tell them that you're more of low risk because you're not getting in contact with the person. Even if there's a COVID positive person on the inside, they're not coming outside to you. You're on the premises. The virus is not just dangling out in the atmosphere waiting for you to catch it. You're wearing your face mask. We do provide the staff with hand washing device that they will have on the bus. So it's like a bucket with a tap, and we give them liquid soap, and they have single-use tissue. So you can, conduct, and the bus is following you when you go around, so you can do your hand washing. So you just make sure that you maintain your distance. If you have to touch, you might remove in the cloth to look inside of the drum, or you may hold on to the gate to get inside. You just do your proper hand washing, because once you wear your face mask correctly, you maintain your physical distancing, you frequently wash your hands, you'll be okay. So we had that. So one of the things that we started off drawing for the first time, we started to do our OB trapping. So we started that this year, but it didn't really come off so well. Because you see, we were using some cup, it was small cups we were using as our OB trap device. So when we went back after a week, there's no water on the inside, all dried up. So after we were advised that the cups that we were using, they were too small. So we plan to restart that process because we want to get a count. So we want to be able to send off egg samples to CARPHA so we can know if we have any new species of mosquitoes that we have. So we're gonna start back that process. Hope we get it right the next time. And we also started using our Sentinel Traps. So we were placing our BG traps we were using the areas where we had high counts for suspected dengue cases. So we're trying to get an idea, what is the look of the mosquito population in those areas where we had, like, for past 3 years, we had 3 communities always topping first, second, and third as our highest area for suspected dengue cases. So we start using our traps, our Sentinel traps there. So there's some pictures of the staff out in the field while we're doing our testing, our setting up. So we place our BD traps. We also were using the gravity traps, and we had our CDC light traps, and replacing them in the field. Well, we didn't catch anything in our gravity traps. We more caught things in our BG Sentinel traps. So we were able to take our samples to the lab, but it's not like our lab, we're in partner with our main lab here in Antigua government lab, the Analytical Services. We were able to take the samples there, separation, the count from male to female. And we also, got advice and assistance, coming from CARPHA there, so we know what we're doing. And we also had a training from a different group. And also for this, we received some tablet devices from CARPHA, which we do really appreciate it. We really appreciate, and we started to input our information into the tablets. We were still using our paper, but we started to input information into the tablets. And so now when we calculate the information, it reduced there is no human error, but we were still having a little issues when we tried to upload it to the cloud, where we were getting duplication. So we're still working on that. So we were placing, as in the picture, we created barcodes. We got permission from our telecommunications company to place our barcodes on their meter. And so when we go to the areas, we scan the information. So we got the homeowners, their name, information, the house count, what type of catchments they have, so we can, proper monitor what the situation in that area. And because what was happening with our neighbor Caribbean islands, such as St. Vincent and St. Lucia, where they had an outbreak of dengue fever, we didn't want that same situation to happen in Antigua. because persons were more focusing on COVID. So what we did, we started a campaign in October, in the month of October, and we visited the school, churches, and clinics. And those school, churches, and clinics were in the area, dimension where we had our high suspected cases of dengue. So we went to all the schools, all the churches and clinics in that area to educate them on what we want them to do, make sure that they check their breeding sites on a regular basis, point out the breeding sites to them. So we had a theme for that campaign. So we created two flyers. So the theme was toss it out, clean it out, keep it out. So, and we got props. So we created props for everything to make sure it was, interesting visual presentation. We do our, just a 10 minutes pitch. So we got persons, to understand what it is. So inside of our bucket here is our mosquito delivery room. Inside we had lava and pupa on the inside and some water. So when we said toss it out, they went flying out. And we were telling the person when we said clean it out. So we had our flower pot saucer there with some lava on the inside and water. So we want you to clean it out. We want you to remove things that may be attached to the side. And to keep it out, it was just as simple as, so my cursor, is just a place to cover on the bucket. If some persons, they don't want to throw any bait inside of their water supply. So with all of that, it's just simple, just cover it. If you cover it properly, the mosquito cannot enter. You don't have any mosquito breeding sites there. So that was our campaign, going out. So this is just a picture. We went to the school and we had our setup at the clinics. So we went to the clinics in the morning when they had elderly care, when they had child health day. So we got that audience. And this is just a little miniature model that we created of a mosquito, our typical yard. On the one side of the yard is what is not supposed to be, or is not supposed to look like, and then on the other side of the yard is what it's supposed to be. So we had the drums uncovered, we had bromeliad plants, we had tires thrown down inside of the gutter, and you can see it have leaves inside the gutter, which cause blockage. So we tried to make it interesting for the audience when we're doing our pitch, so they can, understand and catch it, because it's been a while we're telling persons about, mosquito, and we still have a lot of breeding that is taking place. So we leave out the Spanish community. So we had one of our doctors who studied in Cuba who came along with us so he could, translate information, tell the Spanish community, same thing about the dangers of the mosquito breeding site. And we went to all the radio stations in Antigua to share the message during that period of time. And we still had the staff going out doing their regular checks in house to house, making sure that homeowners are doing what they're supposed to do. And we still doing the treating also. And we also tried to create it for, when we talk about health education, was one of our environmental health aides, the little crafting, doing these type of things. So she created word search. So we place a word search in we partner with one of our newspapers. So every Monday, we place one word search in the newspaper, hoping, it capture persons. So it's like a fun way to learn. And then we'll give them the answers for the next week. And we try to, use pictures. One of the recommendations come from Reg. Try to use pictures from this with the staff, that, get the staff involved in it. So we have a picture when the staff going out in the field for every week. And then this was done by one of our junior public health inspector. So I guess since this will more capture guys, it's the comic kind of script where he making mention of about mosquitoes. So we haven't started distributing this one here as yet. So we're just waiting on the government printery. So just print out some for us. So we can, when we're going on to schools now, we have something that, I guess young boys will, gravitate it, and he's planned to continue with this. So continue the series, he's making a little book. So I do try to engage the staff, what other skills that you have, let's utilize it and incorporate it. in the work. So for this for what we have there, we actually on number CB8 fun facts number 11. So every week the young lady will create one of this for us. And we run out the things, the mosquitoes, we move on to food or something else.
Okay, Julian. So I just wanted to say thank you so very much. We've actually gone a bit over time. So I think what we're going to do is just conclude here for today. All right. And no, this is all extremely interesting. And I'm sure a lot of our member countries would very much like to probably get some more example of the health promotion messaging and activities that you're carrying out, because they really do seem quite interesting and engaging. All right. But at this point, I think what we're going to do is just close off and just ask our participants if there are any remaining questions. All right. Okay, so I'm seeing one popping up here. Yes, so Neri, that's our Chief Environmental Health Officer in St. Vincent. Just wanted to congratulate both you, Jermaine, and Ms. Mannix on an excellent presentation. And just to say that, you know, the battle is shared, and, you know, there's solidarity there in the efforts and the regional efforts. So we all will work very hard with our member states to try and ensure that we can mitigate some of the problems that have been highlighted. And we are in the process of working with you at the moment. All right, just any other final questions or comments? Okay, excellent presentation. Yes, very much so on behalf of our member countries. All right, so if there's nothing more, I'm just going to hand over back to our moderator. Julian, could you just stop sharing, please?
No problem.
All right, thanks very much. So I'm just going to hand over back to Ms. Garcia to round up, and we'll just give you a couple of details as we close on the logistics.
Thank you, Dr. Udram. I'd just like to say again, very good presentations from both Mr. Lake and Ms. Mannix. Very innovative ways of doing outreach. If there are no further questions, in closing, I'd like to thank everyone for coming and participating in this webinar. The questions today were excellent, and we encourage you to continue the conversation. If you require any support, we are here to help as best as we can. In the chat, you'll find the link to the evaluation survey that was previously mentioned. You will also receive it in your email as a follow-up to your participation today. On completing the survey, you will see a final question with another link to a Google form where you will log your name and address. Your certificate will be emailed to you within a week or so from now. Again, thank you everyone for coming out, and we hope that we see you again at future events.